especially in the world of Google, where you can find anything you want. So let's get to it. Myth number 1. So everybody here, we've all had experience with the light adjustable lens, of course, right? So patients who have been poor monovision contact lens wearers are bad LAL candidates. I hear that all the time. So Ken, why don't you lead it off? I mean, is that something you hear? How do you handle that? Is that a myth? Is that true? What do you think?
I think it's a myth. I personally have the LALs. I can't do monovision to save my life. It's not happening. And what I tell patients is, it's not monovision because of the depth of focus of these lenses and the range of focus. We're really only offsetting the eyes a little bit, a couple clicks, minus 0.5 or minus 0.75. And it's very adaptable. And I don't, I try to move away from the monovision. I say I don't compare these to contact lenses because they're in the eyes, and the range of focus is such that we don't have to think that way. If you think of true monovision, we're using monofocal contact lenses, one point of focus. So if we put one out there and one up here, we do that. That is very different than what we're doing in a light adjustable lens. We have a range of focus and they overlap. And so, I refer to the blended vision a lot, where we might offset something slightly, but we're not, I do think that's a myth, that especially with the LAL plus, it doesn't take much to offset to get that near range in there comfortably.
So Ken, when you're doing, monovision or blended vision, how much do you end up having to sacrifice in the non-dominant eye typically?
Really, not a lot. Most of my patients, will maybe they can get 20/20 minus in that non-dominant eye or 20/25. I think that's realistic. And they're J1 plus at near. So I don't go for a big offset at all. I actually start out very modest, and that usually gets it.
Yeah. Josh, anything to add there? I mean, what do you
think Dr. King was totally right. I really like his term of the blended vision. I completely agree that it is a myth. In my experience, pretty much everyone, if they, if the cornea is pretty darn good, there's no big issues, has great outcome with LAL. And I do, just like Dr. King mentioned, when I'm doing the adjustments, I do not all, but most of the adjustments with the Williamson Eye Center down here in Baton Rouge. And, I'll start off just offset a little bit. And those patients will tend to come and end up with 20/20, 20/25 distance, more often than not 20/20. And then just like you mentioned, that J1, maybe even J1 plus up close. So in my world, monovision kind of is a non-factor in regards to a patient being a non-candidate for LAL. Everyone's really a candidate for LAL. Even disturbed corneas, they know the fact that as long as they understand that this is the best technology that we have out there to give them the best vision possible after cataract surgery, even those folks
Right.
are a great option for LAL. So definitely a myth.
What about you, Neil, from the surgeon perspective? I mean, let's say you've got somebody coming in with dry AMD, they got some macular changes, or, I mean, even patients who may be getting active injections, but things are pretty quiet at the macula. Somebody who's monovision, that's something you could consider in those patients?
Oh, absolutely. I mean, yeah, I think, I agree with the other guys that I think it's definitely a myth. I mean, to the point now where I don't really even bring up monovision history very often in these patients because, I think it is very fundamentally different than monovision. The conversation I have with my patients, I agree. I use the blended vision thing a lot, but usually what I tell them, especially if patients have brought up monovision or if their referring optometrist said, hey, they've done monovision, didn't tolerate it, or whatever the case may be, and at least have some of that history, I'll say, hey, look, with traditional monovision, in a best case scenario, each eye is doing 50% of the work, right? And most of the time, it's not that, right? It's like one eye is doing 25% of the work, the other eye is doing like 40-50% of the work, and there's going to be a gap in your vision if you're presbyopic, right? That's just what we know about our presbyopic monovision contact lens patients. This is like both eyes are doing 80% of the work, and so it's like you're not really missing much, and you're not losing stereo. You're not going to have issues where your eyes aren't working together, because if you close your quote unquote distance eye, your distance vision will likely be better than it is today, and you won't notice a difference. And that, I think, holds pretty true, certainly with the LAL plus, but I think even with the LAL as well.
Yeah, I think that I hate to interrupt, but what Dr. Neal just said was super powerful. I've never heard it worded that way in regards to monovision being, one eye getting 20%, one eye getting 40-50%. That's a great pearl. I'm going to take from that here.
I was going to say, I'm going to steal that.
Yeah, me too.
You got it.
That was great.
I think that's a great way of putting it. I always use my hands, right? I played baseball in high school and a little bit in college. So I always talk about, man, if you gave me, I hate it when patients come in after we've done a bit of a blend and they do this thing, the refractive salute, where they're looking. It's like asking me to throw a baseball with my left hand. It's going to look terrible. But man, if you give me 100 pounds to carry up a staircase, it's nice to have both hands. They have their gives and their takes and the balance. You're trying to treat the whole system. And it's really important, I think, for patients to understand that it's not just an individual eye treatment that we're doing. It's the whole system, the brain's included. And so that blend is very tolerable. Ken, let me ask you this. I mean,
Sorry, hey, Nick, I just want to add one more thing before we jump in. Just to piggyback on that point. The other thing that I talk about, which I think is really helpful in these situations, is reassuring the patient that the beauty of this technology is you can go backwards, right?
Yes.
So, I think patients always worry, oh my God, what if my brain doesn't handle this? Especially the really analytical patients who read about the technology, and look into the data. And we all have patients like that now that data is so readily available. And I'm just like, hey, look, after your first adjustment, if you feel like your eyes aren't working together, we'll back it off. And the only downside is you might lose a little bit of near, but you're still going to have, 80% or 90% of the range that we're looking for. And most patients are like, oh, I like that idea. I'm not committing to anything today. So I think that works out really well in these patients.
Yeah. That sense of control, I think, is so powerful. And people really love that. Almost too much. It's like if you give a mouse a cookie, they want a glass of milk and they're going to keep going around a circle. So you do have to still drive as the doc in the exam. You still got to drive, but giving them options is great. Ken, let me ask you this. So there's a way to broaden the depth of focus with the LAL, and it's kind of a unique set of circumstances that you have to hit to broaden that depth of focus. Can you talk about that maybe a little bit?
Sure. I mean, to broaden the depth of focus, we want to, what we call, set off the negative spherical aberration in the non-dominant eye. So you need to move it, when you do your first adjustment, you can set off that negative SA by taking that eye at least to minus 0.5. And that will broaden the range of focus in the non-dominant eye. And you don't do that in the dominant eye. And that gives you an extra boost to the near without moving it back away from the distance very much. And it actually works very, very well. And so you need to go at least in, a half diopter to minus 0.5 or minus a half to get that to happen. And there are times, I'm going to be real honest here, that I don't even have to do that. I may not set off that negative spherical aberration, and I'm still getting, with the LAL plus, I'm still getting the near I want. Because then if you have a patient who's a little iffy, then you're able to, about their monovision or their distance or their eyes working together, they can, we can bring them in a little bit, and we don't have to necessarily set that off, and they still gain some reading with just a little bit of a blend. Is that kind of what you were looking for there, Nick?
Yeah. It's the first treatment, I think, is the key there too. I don't know if you mentioned that.
First treatment.
Yep. First treatment moving in towards the myopic direction. Both meridians in your power cross have to either stay neutral or steepen. So they have to move. You can't be moving in a hyperopic direction. You have to move in a myopic direction. That first treatment, you will induce added negative spherical aberration, which works to broaden the depth of focus even more. It probably gets you, in reality, maybe a quarter to a half diopter of broadened depth of focus. And so you can combine that with, especially the LAL plus, which is already getting you probably an added quarter or a half And you can take that, and for my LAL plus patients, we're not going much further than -1 in the non-dominant eye pretty routinely. I mean, we don't really have to.
No, you don't.
Yeah, I mean, rarely am I going any further than that. Because once you do that, then you are getting into a more true monovision, and that defeats the purpose. And patients maybe who are very tolerant to monovision contacts, we may push it further, but they're just used to that. You're losing depth perception a little bit if you go further, but they're still functional if you don't, and that's the goal. I tell my patients all the time, you should be able to see your phone very comfortably. You should be able to do casual reading pretty comfortably. Computers should be a piece of cake. It's the knitting or sewing or things, tying fishing lures. I got a lot of fishermen up in Wisconsin. I can't see my well, yeah, that's tiny stuff. Let's be realistic here. And that's where you might need to pull out those cheaters. But for your daily functional tasks, yeah, you really shouldn't need it. Anybody else have anything? Yeah, Josh, go ahead.
Yeah. When we've been doing LAL for a little while now, years, and gosh, as soon as I don't remember who told us or when the change happened, but as soon as we started kind of shooting for that -0.5 target on that first adjustment in that non-dominant eye, it really did improve a lot of our patients' reading. So you're not kidding about shooting for that, -0.5 in that non-dominant eye. It really did make a big difference in us. We've been doing that for a couple of years now, but as soon as that change kind of went into our protocol, what a difference.
Is there anybody you wouldn't want to do it on?
Ooh, yeah. Any kind of RK. We have a lot of RK patients down here. Louisiana and Florida was like RK. So we had so much.
Texas is not far behind.
Yeah, I would bet. Yeah. So, I just find that with all the different aberrations that those folks do have from that cornea, inducing any other aberrations probably not the best idea. So in my experience, I haven't had a lot of luck with that. With RK patients, man, I'm just shooting to try to give you the best possible, overall vision. And they know they're going to have those fluctuations even with this great technology. So really the RK eyes.
Yeah. Same with us. I mean, RK kind of is great with this. I don't shy away from RK like I would any other procedure because their corneas are almost like multifocal contacts to begin with. They've got depth of focus. Their vision qualitatively is probably trash, but they do have range of vision and they're used to it because RK was done 30 years ago. And so we can use that to our favor. So we can target plano for these eyes, and yeah, they're going to fluctuate, but they're usually pretty damn happy with their outcome.
Can I ask y'all a question? Because this has been on my mind, and I don't know, when you have an RK patient and you see a lot of aberration on the pentacam or whatever, would you ever, do you think about LAL versus LAL plus? Is that something that enters y'all's wheelhouse? Because I don't. I'm kind of wrestling with that a little bit. I'm like, because all of a sudden I have like 3 RK people walking in the door. So I'm just curious about y'all's thoughts on that. I'm looking for some input there.
Yeah, I don't. I mean, just to jump in. So for me, to Josh's point, in an aberrated cornea, like try not to add any more aberrations to the mix, and I kind of had the same philosophy before I had LAL in my practice about multifocal EDOF IOLs and like post-refractive surgery patients or certainly post-RK patients. I was like, unless it was a really, really slam dunk looking cornea, I always tell people like, there's a lot of really smart surgeons out there who can like quantify aberrations and match them up. Like, I don't think I'm like that smart. And so for me, it's, if I don't know, I'm going to be able to make this optical situation better. Like, it's better just to kind of be conservative. And so the approach I've taken is if this was a patient that I would consider an EDOF IOL in, I'll put a plus in. If it's not, then I'll stick with the IOL. And so far, we've been doing this about a year now. And I feel like that sort of philosophy has worked out pretty well. We haven't had too many, wild surprises doing that.
Thanks.
That's what we
appreciate
do.
That.
If you do an EDOF lens and an eye, do a plus. If not, do an LAL. The LAL, I mean, when you look at the data points, the LAL versus the LAL plus, technically you're probably giving up a letter or two. It's very, very little. But right. I mean, in refractive surgery, you're trying to control all the variables that you possibly can. That is a controllable. So don't give anything up if you can avoid it. That's my philosophy, at least, just like what you said, Neil. I think that's totally fair.
Thanks.
One thing I'd like to add too is with those RK patients, and again, it sounds like Dr. King gets a lot as well. Most of our RK patients do understand they're never going to be perfect anymore. They've got a bunch of damage to that cornea. And if you tell them, hey, in my opinion, this light adjustable lens is going to give us the best outcome and the best chance of giving you your best overall vision, because you're going to heal up probably a little different than everyone else after cataract surgery. And we can kind of take that into account, because guess what? We can adjust your prescription after the surgery. It usually makes sense to them. And there's something very powerful letting them know, hey, this is the best we got for you.
Yeah.
Perfect.
And just to add to that point, I think the other thing too is, obviously like discretion is the better part of valor, right? You want to be, to your point, be conservative. But at the same time, I think my philosophy on cataract surgery in these RK patients has definitely changed, because, I used to think, hey, I'm going to take their cataract out, I'm going to put a monofocal lens in, and then they're going to go back to wearing glasses or contacts or whatever they did before. This is like medical cataract surgery, get the cataract out because it's a problem. I think as my confidence in our LAL program grows, you start to realize that these patients have appetites for glass independence just like any other patient, maybe even more so because they had a long time of really good vision, and I think if you're not offering these patients a technology that you think has a good chance of giving them this outcome, I think you're kind of doing the patient group a little bit of a disservice. And so I think that's where, as you kind of get your feet wet with this technology, and once you start seeing, hey, this is really good, as long as you temper expectations, to your point, I think it's a go in most of these cases.